we've all been blown away the last year with the COVID-19. So we're all stuck in offices and we can't meet personally. We would have loved to have met face to face to do this, but here we are. I suppose sometime down the line we will get to see each other, hopefully in the healthcare industry, at a hospital, or possibly even at university. Okay, so I'm going to talk very basically about organ donation.
Rick, I'm so sorry. Can I just, so sorry to interrupt you. I just want to let you know that we're recording the seminar. So if you guys are okay with that, you are being recorded and we'll upload it onto our site.
No problem at all. Are you able to see my notes as well, or are you just able to see my slides?
Just your slides.
Okay, fantastic.
Thank you.
So can I go ahead?
Yes, you can. Thank you so much.
Okay, thank you. All right, so some of the objectives of today's discussion is to discuss some of the challenges related to organ donation and transplantation, to have an idea of the opt-in and opt-out system, and we'll discuss quite a bit about this, just to have an idea of the history of transplant in South Africa, to understand some of the legal and ethical issues surrounding transplant, to understand the brainstem death criteria and what it involves, also to have an idea of the type of donors that we have and who is eligible as a donor, who is suitable, who isn't, and some of the costs involved. Okay, so transplants is something that we don't talk about every day. And like you stated earlier as well, throughout your training course, nobody talks about organ donation or transplant at all. And this is, a life-saving procedure. So organ donation is basically a gift of life. Organ transplantation is a medical procedure in which an organ is removed from a body and placed into that of a recipient to either replace a damaged organ or an organ that's not functioning fully. So organ donation basically gives hope to thousands of people with end-stage organ failure, such as heart failure, kidney failure, liver failure, and it actually improves their quality of life and increases their lifespan as well. In South Africa, we have close to 4,500 people waiting for a life-saving organ transplant. 4,500 might seem like a small number. It actually isn't, considering that we don't get donors on a daily basis. And with only having about 4,000 on the waiting list, it means that, what it actually means is that not everybody who requires a transplant is able to get onto a waiting list because they may not meet the criteria. But we'll discuss this a little later on. So organ transplant is an absolutely remarkable success story in the history of medicine, and there's an urgent need for people to become donors after death. I'm sure you'll agree with me when you get into the medical profession and when you're out there in the hospitals and you see these people with organ failure that you realize something needs to be done. And you guys, as future doctors, are the key to changing how we look at organ donation and transplant. So just moving on to some of the challenges, one of the most pressing factors is actually that the demand exceeds the supply. So the number of organs and tissue is vastly, so the need for organs and tissue is vastly greater than the number awaiting transplantation. The second aspect is the extensive waiting list. So with 4,500 on a waiting list, we find that the majority of the people on that waiting list are waiting for kidneys. And personally in KZN, I know people who have waited anything from 3 months to 15 years for a kidney. So that's a scary thought itself, to wait that long for an organ. And most people don't even get to wait as long as that because they pass on due to their kidneys being, or any of their organs being in end-stage failure. Then there's the lack of awareness, and this is another big problem, because the lack of knowledge on organ donation among members of the public needs much to be desired. So in South Africa, we have the Organ Donor Foundation, which is an NGO, and they are responsible for public education. However, their resources are very limited. They depend on volunteers in each province to be trained so that they are able to hold awareness talks at various events such as workshops, shopping malls, etc. There's also a lack of awareness amongst healthcare professionals. We find that doctors are actually not aware of brainstem death testing. They're not aware of the referrals to transplant teams for counseling and consent. They're not able to advise family members of their options of being a donor. So these are very scary things that people in the healthcare industry are not aware of organ donation and transplant or the need for it. And often they're scared to even broach the subject. The other challenge we have is the opt-in versus opt-out system. So South Africa is an opt-in system, meaning we choose to be a donor. Whereas there are other countries out there who have an opt-out system where you are presumed to be a donor unless you choose otherwise. But we'll discuss this a little later on. Then we've got the religious diversity. So according to all the literature, there's no religion that actually forbids the practice of transplant or organ donation. While there are different views, it is very clear that most major religions of the world do in fact permit, allow, and support transplantation and organ donation. Then, of course, there's the government inertia in implementation of policies to actually push this program forward. In saying that, I know we've had the setback of COVID-19 in the past year, but there seems to be a lack of energy on the side of the government in doing a bit of education on transplant and organ donation, because we need the public to be aware of this as an option. Then, of course, there's the lack of trained personnel. There's a lack of trained coordinators. There's a lack of trained transplant surgeons. And there's a lack of trained anesthetists and intensivists and neurosurgeons who look at transplant or organ donation specifically. We also have a lack of resources, a lack of funding, a lack of facilities, and just a lack of staff available to be able to run successful transplant programs. So we said we'll talk about the opt-in versus the opt-out system, and we'll talk about the Spanish model. So Spain is one of the few countries in the world, and in fact, the first country to adopt a presumed consent policy. And they did this about 40 years ago. And there was a significant change in the number of donors per million population. If you look at 40 years ago, which was 1980, they had a donor rate per million population of 14.3. This increased to 49 donors per million population in 2019. So it went from 14.3 to 49 in that space of time, simply because they changed their policy to an opt-out system. So what happens in Spain is that all residents are presumed to be an organ donor after death, unless they have expressed the opposite in their lifetime. So the presumed consent policy can actually be seen as a positive, because it launches a message to the population that donating is the normal option. So Spain had to rethink in a different way and do things in a different manner in order to increase the donor numbers and run a successful transplant program. The article that's put up here actually suggests that moving away from an opt-in to an opt-out system doesn't automatically increase donor rates. But in saying that, the donor rate per million population has actually increased in most European countries who subsequently went on to adopt the same presumed consent policy. And if we look at this next slide here, we look at the donor rate per million population, with Spain leading the way at 49.6 per million population. You look at Portugal, Spain, Croatia, France. Look at all these European countries that have adopted these policies and have increased the number of donors in their country. And these are your cadaver donors, your brain dead donors, your cardiac death donors, not your living donors. If you look at the United States and the United Kingdom, as well as other countries like Australia, they've only increased their donor rate per million population in recent years. However, they have not adopted the opt-out policy. They still have an opt-in policy. If you look at South Africa, we're in the red zone here at 1.4 per million population, and that is very scary. So can you imagine how long or it would take for somebody to get a transplant in South Africa? people literally die on the waiting list on a daily basis. And you're looking at about 20 to 25 people dying while waiting for an organ. You find the donor rate per million population is far greater in Europe than anywhere else in the world. And unfortunately, my next slide is not very clear, so you won't be able to see the countries very well. But these are the countries in Europe that have adopted the opt-out system. And South Africa is still an opt-in country. So there are many Western countries who have also adopted this, and many European countries, such as Italy, Denmark, Austria, Germany, and Finland, who've adopted these policies, and they've really escalated their donor rate per million population. So some of the basic principles around the Spanish model is that they actually have a transplant network at different levels, at national level, at regional level, as well as hospital level. The transplant coordinators in this country are actually doctors. They're anesthetists and intensivists. They also have nursing staff and paramedics who are trained transplant coordinators. But their transplant coordinators are nominated by and report directly to the hospital director. So if an anesthetist is selected as the transplant coordinator, he is obligated to refer every single death to the transplant team for evaluation, or he himself can evaluate every possible donor for transplant or for donation. So the country, Spain, also has a central office that offers support for organ sharing, and they also maintain a registry. So everything is equitable. So organ sharing depends on the need, the urgency, priority listing, etc. It's not specific per province or per area. They also have continuous medical training for old and new coordinators. So there's ongoing education, and that helps because we tend to forget. We tend to get lazy. We've all had the setback with COVID-19 where we're forgetting about referring potential donors to transplants. Spain also has adequate funding for procurement and all kinds of transplant activities. So they spend a lot of money on things like attention to mass media. So there's extensive propaganda on the benefits of organ donation and transplant. So here again, they're changing the mindset of people, the general public that is, to think about organ donation, to think about transplant, because end-stage organ failure can affect anyone. So you might be completely against organ donation, but the moment it hits home, for example, you may have a mom or a child who's suddenly in need of an organ, you're going to change your mind about organ donation and transplant very fast. You're going to be knocking on my door or that of Carol's or Tracy's saying, my child needs a transplant. So you see how they started changing the way they think and the way they did things. In saying all of this, despite having the policy of presumed consent, from a legal and ethical perspective, written consent is always solicited from the family. So Spain will always still get written consent from family members. And this is in keeping with international guidelines. Okay, I'm sure you're going to have questions about this later on. So this takes us now back to the history of transplant in South Africa. But before we go on, I'd like you to watch this little trailer. It's a 1-minute trailer, which will give you an idea of a very significant day in the history of transplant. It's a trailer from a movie called Hartstocht. So a lot of it is in Afrikaans, so please excuse that, but I think you'll get the gist of what's happening here. I hope it plays well. Okay, so this movie, Hartsook, is based on a real life story. And it takes you back to South Africa, which, changed the world and inspired the world in transplant, really. So the picture that I have above here now is actually from a newspaper clipping that was in Groote Schuur in 1967. You see the little X on there, that actually marks the spot of a motor vehicle accident where a 25-year-old mom was hit by a car. A 25-year-old woman and her mom were hit by a car. And this was very close to Groote Schuur Hospital. Her mom actually died on impact. And the young woman was taken to the emergency department of Groote Schuur Hospital. And she actually had a very extensive traumatic brain injury. She was declared dead by a neurosurgeon. They did an EEG on her as well, and it was a complete flat line. So this patient was technically brain dead. Okay, and what happened next was truly amazing. The doctors in the hospital had approached the father of this young lady to donate her kidneys and her heart. What happened next was even more amazing. He thought about it, but didn't take very long to make his decision. And he said yes, and he gave written consent for her heart and kidneys to be removed for donation. So what happened on the 3rd of December 1967 at 2 o'clock in the morning, the doctor started surgery on this young woman in Theatre 1 at Groote Schuur Hospital. Less than 4 hours later, at 5:58 a.m., the donor heart was beating in the recipient. The donor was a young woman named Denise de Waal, and the recipient was a 54-year-old man, Louis, who actually had 2 previous heart attacks and was dying. Okay, this was the next, this picture appeared in a magazine, and this was Mr. Louis, the 54-year-old gentleman who had the heart transplant, and standing next to him is one of the nurses who was caring for him, and his cardiothoracic surgeon. This day changed medical history in terms of transplants. Next picture you're seeing here is actually the young lady who died that day. She was only 25. And here is a very famous magazine, the Time magazine, and only if you're famous do you make the cover of this magazine. Dr. Christiaan Barnard, our very own cardiothoracic surgeon, graced the cover of this magazine. And he was actually a celebrity. He wined and dined with royalty amongst the world. But it was unfortunate that the recipient, although he's doing well, and you can see him looking really well and smiling here, he died 18 days later. It was not because his grafts didn't survive. He actually died of pneumonia. So the autopsy reveals that he had a Klebsiella and Pseudomonas infection that had invaded his lungs, but he had a beating heart. So this was the very first, it was the world's first heart transplant surgery that was successful. So the history of transplant in South Africa. Prior to 1967, we had the first kidney transplant, and that was in 1966. And then, of course, 1967, Dr. Christiaan Barnard did the first successful heart transplant in the world. We made history again in 2014, many years later, where we did the world's first penis transplant, and this was done by a team from Stellenbosch University and Tygerberg Hospital. 2018, we made history again. We did the first liver transplant or partial liver transplant from an HIV positive mom to her HIV negative child. And to date, this child is still negative. So the child went on immunosuppressants for the transplant and was also on antiretrovirals pre-transplant and post-transplant. So today, transplant is not seen as experimental anymore because almost all internal organs can be transplanted successfully. So these are just all your solid organs. Just look at the next picture. I know it might not be clear again. We find that tissue, such as skin and cornea transplants, were actually done long before solid organs. So the first corneal transplant was actually done in 1905, and the first skin transplant in 1917. So that's basically the history of transplant in the country. Next, we just move on to something a little more important, which is the Declaration of Istanbul. And it's basically, it revolves around organ trafficking and transplant tourism. So to address the growing problems posed by these unethical activities, the Transplant Society and the International Society of Nephrology, they convened a summit in Istanbul in April 2018. The declaration expresses the determination of donation and transplant professionals that the benefits of transplantation be maximized and shared equitably with those in need, without reliance on unethical and exploitative practices that have actually harmed poor and powerless people around the world. So it aims to provide ethical guidance for professionals and policymakers who actually share this goal. Organ trafficking actually relates to the removing of organs from a living or deceased donor without valid consent in exchange for financial gain or advantage to the donor. So in the context of this declaration, they define the term resident as somebody or a person who makes life within a country, whether or not as a citizen. The term non-resident is a person who travels to and resides in a country temporarily for the purposes of obtaining a transplant. In 2007, it was actually estimated that up to 10% of the world's transplants actually involve such practices. And South Africa was actually part of this as well. But a lot has changed, and South Africa has revised the National Health Act, which came into play in 2003, which still incorporates the Human Tissue Act as well. And we'll talk about this just now. But it actually clears out and irons out all these gray areas. So our policy is now purely black and white. So we do not have the issues of organ trafficking or transplant tourism in South Africa. In saying this, it does not mean that people from our country and other Western countries or wealthy countries or people with money do not travel to poor countries and get transplants from living or cadaver donors in those countries. It still happens. Because I can guarantee you that I have patients who have been on my waiting list for a kidney who have in recent years traveled to places such as Pakistan, China, India, and have gotten transplants. When we think about the ethical and legal practices, it makes us wonder, where are our morals when we do such things? What are we doing to other families out there who are poor and powerless and helpless? Because the money that's paid for a kidney can be finished in a day or a week. And what happens to that family afterwards, especially if they become unhealthy after donating an organ? These are just things to think about. So that brings us to the ethical and legal aspects of organ donation. And in South Africa, the Department of Health governs the practice of organ donation and transplant. They actually provide licenses for public and private hospital sectors. So not every hospital in the country is a transplant hospital. In KZN, the transplant hospitals are St. Augustine's, which is the Netcare Hospital, Life Etabeni, Albert Luthuli, the government sector, and Busa Med Gateway are the transplant facilities in the country. Our organ donors could come from any hospital, though. So the National Health Act of 2003, Chapter 8 actually discusses transplants of organs and tissue. And it's quite specific. It's very detailed and very thorough. It's on par with international guidelines. And what Chapter 8 actually says that in order to declare somebody brain dead, it has to be done by two doctors. One of them has to be a consultant, and both have to be independent of the transplant team. So no member of the transplant team, for example, if I have a nephrologist who has patients on my waiting list, he cannot do a brainstem death test on a patient, simply because he has patients waiting on my list and it's not as objective. The other thing that Chapter 8 states is that we have to obtain written consent from a next of kin, and the next of kin could be a parent, a sibling, a child, or a life partner. It also states that it's illegal to give or receive rewards for any organs. Talk about the other aspect about deaths. There's natural deaths and unnatural deaths. Your unnatural death, we have to actually acquire consent from a forensic pathologist. For example, if it's a gunshot wound to the head or the chest, we have to consult the state pathologist and he will decide on whether to give consent or not, and for each organ specifically. We find that in the UK, a family's wish may not prevail over that of a potential donor under the law. So if a patient is a potential donor and the family says, no, we do not wish to donate, the family has no right under their law. But if the doctor is permitted to the doctor is permitted to decline to proceed if the family objects. However, in South Africa, things are very different. It is your family who has the say over what happens over your dead body. So in South Africa, the family's wishes to donate or not to donate takes precedence over the potential donor's wish. So these are also things that we need to have at the back of our mind. And that is why it's important to talk about organ donation and transplant while we're living, so that our family knows what our wishes are. And they're more likely to respect our wishes when we die than if they had not known, because then they could be making a decision you would not have wanted. Okay, so with regards to the brainstem death test that's stipulated in the National Health Act, there are very specific tests that these two doctors would have to complete. And like I stated, they must be independent of the transplant team. So the criteria for brain death testing has to be strictly adhered to. It has to meet the medical guidelines, the legal guidelines, and the ethical criteria in South Africa and internationally. So some of the aspects that you might see on the slide here are things like pupil response, pain reflex. So these are the things that needs to be absent in a patient who they are declaring brain dead. So there'll be no spontaneous movement, no pupil reaction, no response to a pain stimulus, no spontaneous breathing. However, this patient may still have a heartbeat if they're on a ventilator. Okay, so these would be your these would be your heart beating donors. In terms of the time of death would actually be defined by at the time that the doctor has done the brainstem death test, not when we go to theater and remove the life support machine or remove organs. So for example, if a doctor has declared somebody brain dead at 10 o'clock this morning, but we only go to theater to remove organs at 8 o'clock tonight, your official time of death is 10 a.m. in the morning. And that is what should appear on a death certificate of a patient. So why do we do brainstem death testing? So one of the main reasons is that we want to prevent unnecessary prolongation of treatment. There's no point keeping a patient on a ventilator for days and weeks when we could diagnose a patient and give the prognosis early on, because this would also increase costs. It would give unnecessary hope to a family. One of the other reasons we do brainstem death testing is for organ preservation, so that organs may be retrieved for transplantation. And we also don't want to mistakenly diagnose somebody as brain dead prematurely. So we adhere to the testing, the very specific tests that are set out in every hospital facility that has to be complied with. Also for transparency, so that you are able to give the family a proper diagnosis and a proper prognosis, so that you can be honest with them. And you can also give the family a chance to make an informed decision on organ donation, so that they can think about this before they decide to say, no, we are against organ donation. Because if we do not give them the option or do not give them the opportunity to make this decision, they could have regrets. Because later on, when they open up a will, they might find out that their loved one wanted to be an organ donor. So here again, it's important that medical personnel discuss this with family members at the time a brain death test is done, so that they can think about what they really want for their loved ones or what their loved ones would have wanted for themselves. Okay, then there's different types of donors that we get. We get donation after brain death, which is your heart-beating donor or your cadaver donor. You get donation after circulatory death, and this is your non-heart-beating donor. And finally, you get your living donors. So your donations or your donation after brain death is actually any person who is declared brain dead due to some kind of natural or unnatural injury. And this could be a traumatic brain injury from a motor vehicle accident or a gunshot wound to the head or an assault. It could be intracerebral hemorrhage or infarction from a stroke. It could be cerebral hypoxia from drowning or carbon monoxide poisoning, anesthetic complications, traveling at high altitudes. So these are examples of cerebral hypoxia that could lead to cardiac or brain death. Then you get drug overdoses, suicide, such as strangulation, poisoning. So these are all of some of the reasons that somebody could be declared brain dead. With your donation after circulatory death, it is when your heart actually stops beating. So with your brain dead patient, they would still have a heartbeat. They would still be on a ventilator and have a heartbeat. It's just that their 12 cranial nerves are not functioning, so that they're not able to maintain their own breathing. They're not able to move spontaneously. With your cardiac death, it is very different. It is when your heart stops beating. And it is specifically defined, and the article that's attached to the slide here defines cardiac death when there is a minimum of 5 minutes of continuously observed and monitored absence of circulation, apnea, and a coma. So it is at this point at which death can be diagnosed. I think this is something that you would see when you get into the field and when you get to do your clinical work. If we had to compare your donation after circulatory death compared to brain death, and we look at the graft survival, it is very comparable. Because if you look at the long-term patient survival and graft survival with donation after circulatory liver and kidney grafts, we find that it is equivalent to those obtained from donation after brain death grafts. So that's actually good news. However, we seem to do in South Africa more donations after brain death than cardiac death. If you look at the liver specifically, the lungs, the survival is actually better for donation after circulatory death recipients than for brain death recipients. And I mean, these are very long-term survivals. To look at 5-year survival of a lung transplant, that is actually quite long. We find that often lungs do not survive. The survival rate is normally about 65%, whereas livers and kidneys last a lot longer. But these are just the short-term studies that were done. If you look at the heart, on the other hand, the results from this study suggest that heart transplantation from a circulatory donation actually provides comparable short-term results to a traditional brain-dead heart transplant, and that can actually serve to increase heart transplantation in very well selected patients. So this again is comparable to your lungs. So we find that all your chest organs actually do better from circulatory death or cardiac death compared to brain death. And your brain death actually has a heart-beating donor. It doesn't seem right, but the studies suggest otherwise. And then finally, you have your living donors. And this, it's more common to donate organs while you're still living or partial organs. And kidneys are the most common organs that are actually donated by living donors. And other organs that can be donated while you're living is a lobe of a lung, a partial liver, and also partial pancreas, partial intestine. So not everyone meets the criteria or the requirements to be a living donor. Donors are actually carefully selected in order to avoid outcomes that are medically and psychologically unsatisfactory. So while individual circumstances for each potential donor are discussed privately and tested tested to determine compatibility, all potential donors must be genuinely willing to donate. They must be physically fit, they must be in good general health, and free from conditions such as high blood pressure, diabetes, cancer, kidney disease, and heart disease. So any individuals that are considered for living donation are usually between the ages of 21 and 60. They have to be mature enough to be able to make that decision. Gender and race are not factors in determining a successful match. For anyone who's an unrelated donor, for example, a friend or a colleague, these donors, we would have to apply and get approval from the Ministerial Advisory Committee within the Department of Health. But if you're a related donor, for example, a sibling or a parent, we do not need approval from Department of Health. Who is suitable to become a donor, or who is not suitable to become a donor? If we look at somebody who's died and we do not know the cause of death, we actually cannot use any of their organs, despite them having well-preserved organs for donation. In a case like this, you'd have to confirm with the state pathologist. And with an unknown cause of death, it's going to be very likely that he's going to say no to all organs and no to all tissues. So it's very important to know the cause of death. If it's a suicide, we would still know the cause of death. If it's strangulation, for example, or a drug overdose, the cause of death is known. But if somebody is found a day or two later at their house, we would, by the paramedics or police, and they still have good organ function, but we do not know the cause of death, whether it was somebody who was hit on the head or whether it was a person who had ingested something. In a case like that, it is very difficult to determine at the point of donation. So here again, the state pathologist would say no. If you have chronic kidney disease, the chances are you may not be able to donate other organs, because with chronic kidney disease, we find that these patients have hypertension and diabetes, which actually causes the kidney failure. And when you have chronic kidney disease, you tend to have a little bit of left ventricular failure. So the rest of your organs are not functioning optimally. Next is your diabetes and hypertension. And I've put in uncontrolled and I've underlined uncontrolled. So South Africa is very desperate for organs. So if you have diabetes, but it's controlled either on diet or medication, we will still consider you as a donor. But if it's uncontrolled and your sugar levels are sitting in the 20s and 30s all the time, then you would not be considered as a donor. Anyone with active resistant infections, such as your MRSA, MDR, XDR, TBs, etc., you will not be considered for donation. You have a Klebsiella infection, CRE, C. diff, etc., we will definitely not consider you as a donor. Hepatitis B, again, we will not consider you as a donor. Hepatitis A, we will still use you. Hepatitis C, we will still consider you if you've had treatment and you are now hepatitis C free. Cancer, malignancy, there will always be a risk, and we will never take the chance of using your organs on any recipient. Of recent, it's COVID-19. It is compulsory for us to now actually do 2 tests on any potential donor. And we recently had a donor in KZN, a cadaver donor, on the 30th of November was when the harvesting happened, and on the 30th of November was the harvesting, 1st of December was the transplant itself. But prior to harvesting, we had to do 2 COVID-19 tests, and both were negative to be able to procure organs. Then we look at the age, and we wouldn't use anyone who's under the age of 18 months or over the age of 75. In saying this, chest organs or cardiothoracic organs, which is your lungs and your heart, we'd have a cutoff age of about 85. Though we have used other organs such as kidneys on patients donors older than 75. I personally, my youngest donor has been 6 years old. I've not done a donor younger than that. In terms of cost, what does it cost you to be a donor? Absolutely nothing. There's no cost to you, no cost to your family to donate organs or tissues. The Netcare Transplant Division or the state sector will actually cover all expenses from the time your family signs a consent for removal of organs. So all costs will be covered. We also do not pay for organ donation, so your family doesn't receive any compensation or remuneration for donating organs. It's purely a gift of life from one person to another. And obviously the buying and selling of organs is completely illegal. What is the process? What really happens? So we said earlier that procurements and transplants cannot happen unless we get consent. That is absolute priority. We must have consent. So what happens then? We have to manage this donor in an ICU. We have to optimize organ function. So if there's a little bit of kidney failure or the electrolytes are out of balance, we have to actually correct all the electrolyte imbalances. We have to replace potassium, for example. We have to increase urine output, for example. And we do this by managing medication, fluids, etc., so that we have optimal organ function by the time we get to theater for harvesting. What else happens during this time? We have to think about recipients. Who are the potential recipients? So we do organ matching in this time. We also have to arrange for theater teams to come out. We have to arrange for a cardiothoracic team, a general surgical team to harvest these organs. And this is quite a process because it's actually quite a dramatic process. It's as you would see it on TV, in the movies, really. We have to arrange flights, helicopters, ambulances on standby, because we also have time frames in which these organs need to be transplanted. So everything has to be in sync and everything has to be well organized. And that's where your transplant coordinators come into play. By the time we get to theater, we treat our patients or our donors with respect and dignity. So the surgical procedures that take place is completely sterile. And patients are sutured. So the chest cavity, abdominal cavity is sutured after the removal of organs. We apply dressings, and then your patient or your donor is now sent to the mortuary. Prior to operation, we have what is called a donor pause. The donor pause is very important. We do this in theater and often in the ICUs so that staff can get closure, so that families can get closure. And we can also acknowledge this donor's life and the gift that they are giving to complete strangers. And I think that that is quite important to acknowledge a donor and for those who are quite religious in theater, whether it's your doctors, your theater scrub sisters, your transplant coordinators, if anyone wishes to say a prayer, they're welcome to do this at this time as well. The other thing we don't do is we never delay funeral arrangements. So we try and procure as soon as possible. Most procurements happen from the time a patient or a relative signs consent. So the harvesting actually happens between sort of 16 to 24 hours later. So there's no time that is being wasted. It's a mad rush. There's a huge adrenaline rush. Everybody's very excited. It's quite important as well for hospitals as well, because it's an amazing thing that's actually about to take place. So from the time of harvest, organs also have a time frame in which to be transplanted. Your thoracic organs, your heart and lungs, have a very short time frame of 4 to 6 hours. So from the time it is removed, we have literally 4 hours to transplant the heart and lungs. So if we have to send heart and lungs to Cape Town, your flight alone is 2 hours. So we always have a paramedic on standby at the theater door and the doctors to get this organ to either a flight that's waiting or to the helipad landing site to get on board as soon as possible. And by the time they get to Cape Town, there's somebody waiting there to help get these organs to theater. And you find that your recipient is already on the theater table and probably under anesthetic already. So it's quite a rush. It's quite exciting. And it's, like I said, as you would see it on TV, no different. Your liver has a time frame of about 6 to 8 hours to be transplanted, and your kidneys have a longer time frame. it has 6 to 24 hours to be transplanted. You notice that I haven't spoken about tissues such as skin, bone, and corneas. I'm leaving that for my colleagues, Carol and Tracy, to discuss. Okay, the other thing that happens during this time is the matching process. So for heart and lungs, we have to look at a blood group match, a compatible age. We also have to look at a size match. For example, you cannot take the heart of a 50 kg young girl and put it in a 100 kg man, or vice versa. It just wouldn't work. It just wouldn't cope. Then we also have to look at a priority listing. And the priority list for heart and lung is actually a national list. For the livers, we find we have to look at a blood group match, and they also have a scoring system for end-stage liver failure. So liver transplants are currently only done by one hospital group in the country, and that's Fitz-Donald Gordon Mediclinic in Gauteng, whereas there are multiple kidney transplant centers and heart transplant centers. With regards to the kidneys, we do more extensive testing on them because the waiting list is so long. We look at a blood group match, we look at a size match, we look at age, and then we look at tissue typing. So we look at your HLA testing, which is your human leukocyte antigen, and we look at a T cell and a B cell cross match on this. And whoever's the best match will be eligible for the kidney, provided they are well enough and have maintained their workup processes as up to date. For example, they've had a recent cardiology consult. We know that the heart's clear, we can go ahead with the kidney transplant. So there's various aspects to look at to actually get onto the list and to be eligible for transplant at that time. It doesn't mean that because you're on a waiting list for a long time that you might be first for a kidney transplant. It's not about a first come, first serve. It's about whoever's the best match. Confidentiality is another important aspect that both the government and private sector prides themselves on. So all information is actually kept confidential, and this again is stipulated in the National Health Act, Chapter 8, that covers transplant. So all information is confidential, except of course in the living donors, where you have the related living donor or the unrelated living donor. The donor is known to the recipient. So with the cadaver donors, we actually encourage our recipients to write letters of gratitude to donor families so that they have an idea or understand what's happened to their moms or their sisters' kidneys or liver, etc. And this helps with closure. This helps them accept the loss of their loved ones. And then they also know that their loved one hasn't died in vain. They've gone on to save the life of a stranger. So in terms of the whole confidentiality aspect, we actually at Netcare would give the donor a unique donor number, and the recipients and donors can only be linked by the transplant staff. So we actually maintain confidentiality as best we can. So to all of you listening to this presentation, you all have a duty to refer once you get into the clinical field. And I've put a little comment here from Dr. Calloway, who's at the University of Pittsburgh Medical Center, and he says, as an emergency physician, part of my responsibility when a patient would be pronounced brain dead or dead would be to notify the organ procurement agency. So we find that in South Africa, there's actually no mechanism in place to refer someone who dies in the emergency department or in the ICU for donation. Yet we have transplant coordinators in both the private sector and the public sector. And some of the barriers, as discussed earlier, would include the lack of knowledge, not knowing who to contact, cultural beliefs, not wanting to get involved, and also inadequate cooperation from doctors. So I just think that, having an idea of organ donation while you're in med school will make you think about it when you have to declare somebody brain dead, either in an emergency room or in an ICU. So I've put this other article out here as well, because there is very little research on the role of emergency medicine and emergency professionals in organ procurement process. And I know that you're all going to do an emergency medicine you're going to circulate within these departments. So these are the things that you're going to be seeing. You're going to be declaring somebody brain dead. You're going to be doing the brainstem dead test on somebody. And while the emergency department is very well recognized for being the front line of combating critical illness, very little attention is paid to the role of emergency medicine in the important public health issue of organ donation. And it is a public health issue. So the article suggests that attention and resources should be directed towards the role of the emergency department in organ procurement process. And I think that that is important. That is where it starts, at the front line when patients come into the emergency room. Some things to consider as doctors or future doctors of South Africa. I think we need to think about looking at a national template for care pathways. We need to look at end-of-life care pathways, probably local and national policies and guidelines on organ donation and transplant and referring. We need to look at maybe core competencies, which, like you said, is not included in your training program. And this should be included in all healthcare professionals, nursing, other medical, and other allied healthcare professionals training programs. Also to routinely incorporate organ donation topics in hospital orientation programs. So even when you do your orientation as newbies in the facilities that you're assigned to, that we discuss organ donation at this point as well. So just to conclude, I just want to say this. I mean, one of the most simplest solution, I think, to increase the number of donors in South Africa would be with the help of the Department of Health. And if they could implement a routine referral policy, compelling all physicians to refer organs to transplant coordinators so that we can evaluate them for possible organ retrieval, for counseling, for getting consent, and to be able to drive a successful transplant program. I just want to thank you all for taking the time to listen to me. I just have a couple of pictures that I'd like to show you from my time in transplant and what I have witnessed in theater. And this is a picture of the surgeons working, and there's two teams here. You can see on the one end, if I just point to you guys here with the laser, on this side, you've got a surgical team, a general surgical team working on getting to the kidneys and liver. And on this side is a cardiothoracic team waiting to get to the heart and lung. Just to move on to the next slide, at the end of this surgery, this is the heart that was removed, and you can see the plastic bag that it was placed in. It was placed in a solution called custodial, a very expensive solution. It was a cold solution, and we find that these bags are now triple or double bagged. So this bag would get sealed, completely sterile, and placed in another sterile bag with crushed ice in it. Look at the next picture from the very same harvesting. This is the liver, and as you can see here, it is in this bag. It looks completely pale, so it's drained from all blood, and it's kept on cold, what is known as cold plegia or cold ischemia, until it is reperfused once transplanted. These are just some of my references. It's a very real picture of organs being removed, coming out of the helicopter and taken to one of the hospitals in Gauteng for transplant. And this is exactly what you would see on TV. I would also just like to take the time to acknowledge, if I may, the Netcare 5. You may have heard of the helicopter that crashed last month. And in this picture is one of the doctors that was actually lost in that crash. So we lost 5 members in that crash. 3 of them happened to be from the transplant team in South Africa. I want to thank you all for your time, and just to put this idea in your mind to think about recycling your organs and becoming a donor. My number that's available 24/7 for referrals. Surprise not to you just in healthcare, but to your families and friends out there. So thank you very much. I'm happy to take questions.
Thank you so much, Rekha, for that wonderful presentation, and our deepest sympathies to everybody on the NetKit team for your most tragic loss. Thank you so much for that wonderful presentation. It was absolutely captivating. Okay, so I'm going to look at the chat. If anybody has any questions, please feel free to unmute yourself and speak, or you can message it in the chat and I will moderate it. So I'll just wait for any. In the meantime, I actually did have a few of my own questions, but I limited them to 3. So the first one is, what is the situation regarding the opt-out policy in South Africa? Is that something that is being looked at, or could it be looked at?
Well, it definitely hasn't been looked at, but it's something that we need to look at going forward. The thing is, most Western countries still have not adopted an opt-out policy. So despite the number of donors increasing in places like the US, Canada, the UK, and Australia, they still have an opt-in system. So I think we're a long way from looking at an opt-out system. It would be great if government, and our team in the Department of Health could start looking at this, because the problem in South Africa with diabetes and hypertension being the main cause of renal failure, our lists are growing every day. I personally have 400 people on my waiting list for KZN for kidneys, and I had 70 odd new referrals in 2020, which I haven't been able to look at simply because of COVID-19. So, looking at the opt-out system would be nice. It would definitely increase our number of donors. It would obviously reduce the burden of the healthcare system if we do more transplants. It'll keep patients out of ICUs. It'll limit the number of treatment and medications that they may need. So it is organ transplant is a treatment in itself. So to look at an opt-out system going forward would be great.
But it's a long road. I would imagine with policies and so forth. And I think what you touched on regarding having high diabetes and hypertension prevalence in South Africa, that also plays into, as you mentioned, their eligibility for organ donation. So controlling hypertension and diabetes in our country would also be something that could impact our donor eligibility.
Totally agree. So with the cadaver donors, we have done cadaver donors who are hypertensive and diabetic. We're very desperate. So if we can transplant somebody, a patient from a donor who was diabetic or hypertensive, and if the recipient now goes on to live 10 years without, for example, dialysis, that is 10 years of life that we have given to that patient. So we will not rule out completely a diabetic or hypertensive donor. We will evaluate each one as an individual. And if we're able to control it just prior to harvesting, we might still be able to use organs in that patient.
Okay, no, definitely.
But as a living donor, take the risk.
Okay, would you be able to speak on the ethics regarding Jane Does or John Does and organ transplantation?
Sure, no problem. We actually have had a few of these in the past, but unfortunately with John Does and Jane Does, not having a next of kin means that we cannot get consent, and that is a legal requirement. So it is in policy that we can get consent from the Minister of Health. However, that has not happened to date. So like I said, people, a lot of doctors also don't want to get involved. They're either too busy or there's too much paperwork. So they do not want to make the effort of contacting the Minister of Health or somebody in the Ministerial Advisory Committee to be able to get consent on a Jane Doe or a John Doe. So we have lost these potential donors in the past. And I can't see us getting consent on them anytime soon.
Okay, I would imagine. I know a similar thing has also changed with regards to cadaver donations at the university, where we used to be able to have Jane Doe and John Doe donations for anatomy, but because of ethics, that has changed, and they've now implemented a body donor donation program.
Correct. And it's unfortunate that most of your body donors are actually the elderly. So you're not actually getting the young people to be able to work on and to learn from.
Yes. Okay, so I have one last question regarding this before we move on to Carol. Could you speak about it? And I could be mistaken about this because this is just kind of what I've heard over the years regarding 3D printing and organs. I think that certain things have been looked at with regards to that. So I'm not sure if you could tell us a little bit more about that and its possibility or viability of helping with organ donations.
Okay, so these are all still in the pipeline, and I think there's currently research being done on it. And these are programs that are being worked on in the States and in the UK. I know the UK was working on a 3D heart. I just happened to catch it once on BBC, and it was literally looked like a mesh, but you could almost see a sort of beep or a blip in it, and that was actually the heartbeat. But this is not being trialed yet, and it's not being trialed on humans. I think the States had some kind of kidney replacement that they had developed. It was an external item, so it wasn't even a 3D program of any sort. So I can't see anything happening in the next 5 years. Let's put it that way.
Yes.
And in terms of trials, that's going to take a long time as well. And you can't really do human trials first. You've got to now look at doing it on, unfortunately, animals before trying it on humans.
Yeah.
So that's a scary thing. And, I think there's a lot of ethics that needs to be discussed around that as well.
Yeah, so definitely. So it's not something that's going to be seen anytime soon. And
not anytime soon.
Our best way forward is to increase awareness and increase our donor list. I mean,
that's where we need to start.
Okay, thank you so much for that wonderful presentation. It was absolutely, it was really interesting, so informative. Thank you very, very much.
You're welcome. Is there any more questions from anyone else?
I don't see anything in the chat, so I don't think so at the moment. We can maybe move on to Carol.
I think there's somebody who's wanting to ask a question.
Oh, is there?
Is it Razani?
Oh, please do. Yes, you can unmute yourself and ask your question. Thank you.
Okay, thank you. I might, maybe my question will be very stupid, but
because there's no stupid question.
But because I'm not from a medical perspective, from supply chain perspective. So what I've just asked is that because I heard you were referencing some of the few countries who have been so successful in these donor donations and stuff, if I have to put it that way. I know it's not a correct medical term, but just looking at in South Africa, because we don't really have readily people who are doing this, or only people who are doing this are people who not everyone can be able to access. If that's why you check if you are having all your wellness programs, you will never see such topics being focused at. And you will always just see the people talking about chronic diseases, talking about the other viruses, infection viruses. So that's why I think it defines why this thing is very low in Southern African countries. And I think we need to start, or the government or the such initiative needs to start targeting also those ones who are in rural areas, so that I think the information can be readily available even for those who are willing to donate. And as for issues of people who are diabetic and all other chronic diseases, for them to donate their organs, also it should be able to be shared with them. And we can have this kind of research in papers and everything, but if the research is not well known by other people, mostly in rural areas or privileged one, unprivileged one, which will defeat the purpose of having such initiatives. So I think the best thing and the good thing to do with such initiatives, make sure that it's accessible to everyone, not only the target people from the medical industry or target people with the high profile hospitals. Because you go to the normal private hospitals, such initiatives are not even there. Some of the people are there, but they're not even aware of such initiatives. Thank you.
Rutani, thank you so much for those comments. You're absolutely right. You hit the nail on the head. So if you look at the population of KZN, we have about 11 million people in KZN, and only about 30% of them actually live in the eThekwini metropolitan areas. And you're looking at close to 70% of them who live in rural areas. And what we find that people in rural areas have no idea about organ donation. They do not have access to facilities either, yet they have the same problems. So they would still have hypertension, diabetes, renal failure, heart failure, etc. And people in rural areas have bigger families as well, which means there may be 4 or 5 children in a family compared to people living in the city. And people living in these rural areas, if they only know about living donation, siblings can donate to each other. And then you could actually boost the economy in that way, because now you have one more person who is not a burden on the healthcare system, who has had a transplant and is probably will be able to work and support their families. So I totally agree with you. So there are some hospital sectors that actually have these programs, but are not implementing it. That leaves us with very few people who are able to do so, but we can only target the healthcare sector. Like I said, we have the Organ Donor Foundation, who is responsible for this kind of public awareness in both rural and city areas. However, they depend on volunteers, and they do not have enough volunteers or resources to be going out and doing these outreach programs, for example, in schools, in communities such as your church groups and other religious organizations, etc. But you're right, there is this inequality that exists in the country. And it's that lack of awareness amongst the entire population that doesn't promote organ donation or doesn't increase our donor numbers. We have to start with education. So with me educating you, I would expect you to now educate your families and your friends and to start talking about these things, because these are the conversations we need to have every day. We could die tomorrow, and if we haven't had this conversation with our partners or loved ones, they would not know what to do tomorrow when you die. So I really want to thank you for that comment about the rural areas, because these people don't have access to these facilities. They do not know about transplants. And the government sector does provide transplant options. And if you look at KZN, Albert Luthuli is the transplanting hospital. But people do not have access to this hospital. I mean, it's going to take people 2 hours, 3 hours finding the transport and all of those things to be able to get to a facility just to be assessed for transplant, let alone getting onto the transplant list. But these are life-saving operations. So yeah, if there's anybody else who want to comment on that. Tracy and Carol, I'm not sure if you have anything to say about Rutani's comments.
No, not at this point, Rekha.
So thank you so much for that. It was a very good point to bring up, and definitely something that needs to be looked at both locally, but as well as within government policies on a high level. It's definitely something that needs mass collaboration across different networks and across private and public. And hopefully, we can see a brighter future for organ transplantation in our country.
Yes, definitely. If you look at this, if you just go back to that Spanish model, so with them it was mass media and propaganda and starting to educate. So they went, they put money and resources into it, educating the public on organ donation. And that is something that we need to do, but we need the help of the government. This has to come from the top. We at this level, for example, me at Netcare or Carol at the iBank, we cannot do this on our own. We do not have manpower.
No, definitely. Okay, so if it's okay, I don't see any other raised hands, but if you have any questions, please just message me and I will definitely bring it up. If we can move on to Carol's presentation. Carol Tennyson is the manager at KZN Cornea and Eye Bank. Carol, if you can share your screen and then you can begin your presentation.
Okay, hello everybody. Thank you for the opportunity to tell you a little bit more about our eye bank. Can everybody see the slide?
Not as yet, but it may take a few minutes or a few seconds to load.
Okay, let me know when it's up.
I will. Thank you so much as well. We really appreciate you guys taking the time out of your day to present to us.
No, we welcome the opportunity to do this. Corneal donation in generally in South Africa now has really hit rock bottom, and it's very, very sad that it's like that. The demand is so great, and COVID has really impacted on us negatively. But irrespective, our donor pool just seems to be dropping more and more on an annual basis. And it is very, very worrying. So yes, the need for awareness is critical, really, really critical.
Definitely. Okay, it still hasn't shown. Could you maybe
shown up?
No, not as yet. Okay, can you just maybe try to stop sharing and try sharing one more time? Hopefully that will work.
Okay. Wow.
No, not as yet.
We're having a little bit of a problem here trying to get this thing to
share.
Okay, we're trying again now.
Sure.
Right. Oh wow, we really are having a problem here.
Okay. Would it be possible then if you
unshare your screen? Unshare your screen.
Serena.
Yeah.
Serena, would you be able to unshare your screen?
I'm not sharing at the moment.
You're not sharing.
Rekha, are you sharing by any chance? Sorry about this.
No, I'm sorry about this.
I stopped sharing.
Stopped as well. Okay, in the meantime, okay, there we go. There we go.
Are you up? Okay, great. Is it there?
Yes.
Okay. Right, how's that?
It's perfect. Thank you so much.
Oh, wonderful. Okay, so we can continue. Okay, basically in KZN alone, there's more than 1,000 patients awaiting corneal grafts, and most of those patients require two. The average age of those awaiting corneals are between 10 to 45 years. And I'll explain basically the most critical dystrophies that these patients suffer with, and the two that take up, generally make up the waiting list, the two dystrophies. These are basically just pictures of to a child and an older person with a corneal ulcer. And generally, if they can't fix that, the cornea perforates or gets to the stage where it threatens to perforate. And a corneal graft is essential to save the eye. And basically, the cornea is just the transparent dome-shaped outermost layer that covers the iris and the pupil in front of the eye. And obviously, to see clearly, the cornea and lens must focus the light rays precisely on the retina. And if the cornea is unable to focus the light properly, then the retina receives a blurry image. So the cornea is critical to our sight. And without it, we really can't function. How can the cornea be damaged? Well, there are many, many reasons. There's obviously injuries. pathological diseases such as Stevens-Johnson syndrome, chronic infections or inflammations. We had a case in Margate. Somebody had gone on holiday and she had forgotten to take her contact lens out. And the next day she was in such a bad way. She had to, the only doctor that could see her and take her to surgery was in Richards Bay. So they had to go through to Richards Bay. And he ended up having we had to arrange an emergency cornea. Thank heavens we had one, because she'd almost lost her eye, and that was just through leaving a contact lens in the eye overnight. Neurological conditions, rare hereditary conditions such as Neridia congenital abscess of the iris. That's basically what it is. These are only a few of many that can cause damage to the corneas. And a condition in which one or more parts of the cornea lose their normal clarity, and they build up a cloudy material. Keratoconus and Fuchs dystrophy are the two most common. There are many corneal dystrophies, but these two make up the bulk. Just to give you a little bit of insight into what they are, keratoconus, they inherited genetic disorders. Keratoconus will start presenting itself when the patient's around about 10 years old. And they battle to see the blackboard. They have itchy eyes and red eyes. They're forever rubbing their eyes. And of course, then they'll go off to the optometrist, and he may be the one to diagnose keratoconus. Keratoconus is a gradual deterioration, but it will deteriorate. It deteriorates mostly between the age of 15 or 10 and 26 years of age, where it generally slows down, but most of the damage is done over that period. What happens is the cornea bulges and it thins. And with that, your normal vision is blurry because you haven't got that optimal shape anymore. So there's a lot of pain with it. And of course, when they rub their eyes all the time, it thins the cornea. Ophthalmologists will manage the condition, obviously, during that period. Some people manage it actually for the rest of their lives. It doesn't sort of progress to the point where it needs a corneal graft. Others, they generally do need a corneal graft. And these kids that are at school and university or just starting work, they battle with driving. They can't drive at night. It's just terrible. So if the cornea thins to the point where it cannot hold a contact lens, then they have to be put onto the waiting list for a cornea, because if that cornea perforates, then it becomes an emergency. If we are not able to provide a cornea in time, then they may do a scleral patch or just do a patch. But if they cannot save that eye, if the infection sets in and they cannot control the infection, they generally lose the eye. So it's like we're in a position where there's just not enough donors, and we just can't provide to these people that end up losing their eyes. So yeah, Fuchs dystrophy affects people that are older. When your endothelial cells, the last layer, the endothelial cells start to break down. And once they start to break down, it affects the pumping mechanism of the cornea. So the fluid balance is not optimal. So the cornea basically fills up with fluid, and it becomes spongy. It becomes basically spongy, and your vision is impaired because of it. And then they also suffer with a tremendous amount of pain as well. So those are the two most common. As I said, it's a gradual deterioration, both eyes affected equally, and can occur in totally healthy people. Donor age criteria from 5 to 75 years of age. Again, this is not an absolute criteria. In an emergency, an emergency, an ophthalmologist will consider an older donor. That they can always do a graft with a younger cornea at a later stage. Sometimes we just need to save that eye from perforating. Exclusion, absolute exclusion criteria: HIV, Hep B and C, lymphoma, brain metastases, leukemia, rabies, sepsis, Ebola, hemorrhagic diseases, and corneal grafts, obviously, and corneal dystrophies is an absolute no-no. And now, of course, we've had to add to that COVID. Questions that we will need to ask from the person who is referring to us: the name of the patient, age, time of death, diagnosis, any other medical history, and we need to know which funeral home the donor is going to, because we will generally either do the procurement in hospital if the donor is still there, or in the funeral facility. Name and contact details of next of kin, and we always specifically, when we do our in-services and our orientations, we make a point of explaining that it is not up to the person that is referring or the staff that is taking care of that patient up until the time of death to speak to the family about donation, organ donation, or donation of tissue. It is up to us. They refer to us and we handle the whole process. Their job is simply to take care of that patient and the family and leave the rest up to us. We will then, once we know that the patient is definitely a potential donor, or the donor is definitely a potential, then we can procure corneas. We will phone, excuse me, sorry, I'm getting ahead of myself. We will then ask for the contact details of the next of kin. We'll phone the next of kin and ask them if they know, if they knew if their loved one was an organ donor, or how would they feel about organ donation. And we do this 3 to 4 hours after the death. So we do require the referral hospitals or the wards to contact us within 3 hours of the death. It gives us time to get any other medical history, to follow up on any bloods that may have been done, and so that we can make an informed decision about this donor. Procurements can take place up to 12, generally are procured up to 12 hours after death. So our time frames are very, very small. Procurements can take place in a hospital environment or at the funeral home. Donors are handled in a respectful and dignified manner, and an open casket viewing is possible. I'll show you in one of our slides, we put a little eye cap in. This is just the process of the corneal procurement. As you can see, it's just the little lens that is removed. It's not the eye. And there's a little lens there. From there, you can see we basically removed it. We take a wide rim of the sclera. The doctors like that because they can use the sclera to do patches. And then we put a little eye cap in under the eyelid, close the eyes, clean it up, and you would never know the difference. So an open casket viewing is definitely possible. Once the cornea has been cured, it's placed in a Life4C solution, which is an antibiotic solution. It's placed in the medical fridge at a temperature between 2 and 8 degrees, and the cornea has to be transplanted within 14 days. Corneal graft basically is, here is a before and after. As you can see, there's an eye that you just can see nothing out of, and that's the difference. There's the sutures. They are microscopic sutures, and the sutures come out between up to 6 months, but it's basically up to 6 months. They start taking the sutures out slowly but surely, and as the sutures come out, their vision improves. And those sutures really can't see them, by the naked eye. You have to look through a microscope to see those sutures. And basically, to refer, it's just myself and Tracy. That is our referral number. All the hospitals have that, but I'd like to just go in a little bit more in terms of who is referring. The private sector are our main referral hospitals. We have a policy in place, and we work with Reka very, very closely, and of course Cindy Goldie at Busamed. The private sector, the hospitals contact us with every single referral. From there, we will decide who we can consider and who we can't. Without this referral policy in place, the eye banks would not survive. There is no other way that we would know that a person has become deceased. There's certainly no database in this country whereby we can just click in an ID number and have a look at the ODF's, the Organ Donor Foundation's database to see who is and who isn't. We are solely dependent on our referral hospitals to continue to refer to us. Those that we don't consider, we keep as stats. The public sector, on the other hand, we've never been able to get that up and running. And it would be, if we could achieve that one day, if we could successfully achieve that, it would change the situation dramatically for our corneal recipients, because the donor pool would then widen, it would open up for us. Currently, the eye bank in Durban is the only functional eye bank. There is one in each province, in Cape and in Joburg. Pretoria is the functional one now. Sorry, it's not just us, it's also the Pretoria one. Joburg and Cape Town have had extreme difficulty, obviously, during COVID. Bearing in mind that we are self-supporting, we are dependent on an income from our corneas. We charge the receiving doctor or the hospital a professional fee. We have to in order to cover our costs. We cannot depend on outside sources for an outside source for sponsorship or donations in order to run this eye bank on a monthly basis. So we have to do that now. Because we're a Section 21 company, we are not able to make profits. The income that we derive is purely to cover our costs and to pay salaries, cover costs, transport costs, refrigerations, computers, all that kind of thing. We cannot make profits. However, if we have a month where we do have an excess, that money just goes straight back into the eye bank. No one receives any additional bonuses. We have a board of directors. They're all voluntary directors. We have a doctor, a psychologist, and a transplant coordinator who is Cindy Galdi. But that's basically our board of directors. If this eye bank in KZN fails due to a lack of donors, then a lot more people in this country and in this province are going to suffer. Some of the private doctors are bringing in corneas from overseas. It's a hell of a price that the patients have to pay privately. The provincial sector obviously are not doing that. They are dependent on us, the local eye bank, for their corneas. So we have to ensure that this program, this eye bank, continues. And we're doing everything possible. I just want to explain quickly amniotic membrane. We're looking at getting that project going in second quarter of this year. Bone SA, and Tracy will tell you more about Bone SA and our collaboration agreement with them. They have just formed a tissue bank, VitaNova, which falls under Bone SA. And they will be ready in the second quarter to start processing amniotic membrane. So we will be able to then get our program running here. For any cesarean sections, it's just a case of the doctor asking the patient if they'd like to donate their placenta. And that placenta will go to the tissue bank in Cape Town. It'll be processed. The amniotic membrane can be used for corneal patches and skin, a replacement of skin, skin substitute for burns patients, because donor skin is the best blessing for a burns patient, but there's a terrible shortage of it, because the skin, once it has been put in place, it takes 14 days to slough off, but it gives the recipient's own skin time to regenerate. And once that skin has sloughed off, the new skin has already started to form. But because there's such a shortage, they are now dependent on amniotic membrane to assist. So we're hoping to get that program up and running in the second quarter, which will definitely help tremendously. So yes, that's basically what I have to ask for now. Just wanted to give you a little bit of a rundown of what we're all about and what our purpose is, and how we're hoping to extend our services with the help of Bone SA, working very, very closely with them. I've spoken to you about corneal tissue and about amniotic and a little bit about skin, but Tracy's going to tell you more about the femoral head program and also the donation of long bones and what Bone SA accomplish with that. Now that they have their own tissue bank in Cape Town, the bone used to go to the Centre of Tissue Engineering in Pretoria for processing, and then Bone SA would buy the bone from them to distribute to the various doctors in needing. But now they have their own tissue bank, they will be processing that bone themselves. I think that's all I have to add for now. I don't know if I've left anything out, but I think I've covered it very, very well. Anybody have any questions?
Hi, Tracy. Sorry. Hi, Carol. Thank you so much for that wonderful presentation. It was really, I have questions. I always have questions, but I'm just going to wait and see if any of the participants have their hands raised or if anything comes through in the chat. But thank you very, very much. And thank you so much for all that you do. Okay,
no, thank you.
It's a pleasure. Elisha has her hand raised, so you can unmute yourself and speak, Ellie.
Hi, Carol. I just want to know, you guys said that you guys can also do the removal of the cornea at the funeral homes. Is it not possible to collaborate with the funeral homes so that, because it makes it a little easier, you know, coming from the funeral homes that are about to pick up the bodies. So is it not possible to maybe collaborate with the funeral homes to try and increase the awareness of corneal transplant?
We have approached them about this on numerous occasions. And unfortunately, with the funeral homes, they're more than happy to facilitate the removal of corneas on their premises. But when it comes to approaching families, they are afraid that they may just offend a family. So what we did was we produced little information cards to give to them, which we gave to them to give to the family, which details a whole list of things, what they will need at the funeral home. And then, of course, we will ask them basically, do they know what their loved one's end of life wishes were in terms of donation or in terms of cremation, burial, all that kind of stuff. There's a few things that we have on that information card that we've asked them to give to the families. And we did this just prior to COVID in March, I think it was last year. And of course, then everything fell flat and, you know, the funeral home wasn't inviting anybody in other than us going into the back to do a procurement. So we've been unable to really manage it. We're hoping that we can start to get back and start managing that again. Yes, because that is a way that families can be reached. Is when they're collecting or removing their loved one from the premises, just give the family a information card and let them just go through it and make the decision for themselves. Sorry, is that anybody else?
Thank you so
much. I hope that
much.
answered your question.
Okay. Thank you so much. I think that actually did answer it very well. Yes, she said it definitely did. Thank you so much. I think again, it touches on the topic that we need to conscientize the South African population about organ donation and change its perception that it's something that is offensive or something that needs to be shied away from or something that isn't acceptable culturally. It's really about changing the perception of it in our country, because you know we do have enough supply of potential organ donors if it was you know what's the word, consented to more often. It's not such that there's a shortage of supply.
Correct. Yes, it's information and it's just awareness.
Exactly. Okay, so I have two questions quickly. What's the success rate like for corneal transplants or eye transplants?
Brilliant. 95% success rate.
Okay.
The only time that a cornea may fail, well, it could be donor related, but every time that there has been a failure, which are few and far between, they've had to look at we've looked at the actual donor, the donor history, medical history, and then they've looked at the recipient. And 9 times out of 10, the recipient has compromised, they're immunocompromised, or there's some issue going on. And that's the reason why, yes, they may rub their eyes incessantly, which can also cause the cornea to fail. So 9 times out of 10, it's not the cornea. It can be patient related. There was another thing I was just going to mention in terms of rejection, few and far between. It's a 95% success rate.
Okay, that's excellent. Okay, then my last question was, is there any sort of matching criteria that needs to be followed? I'm not sure if you did mention it, but I know like with the solid organ transplants, we look at HLA and so forth. Is there a similar, is it the same concept for corneas?
Not at all. Tissue is the easiest. It's one of the easiest programs to be involved in. There's no tissue typing, there's no blood grouping, there's absolutely no criteria at all. All we do is, we need to do is do our virology, and we do an eye swab, an eye MCS. Mm-hmm. Prior to removing the cornea, we send that away, we wait for those cultures to come back. And once we have those cultures back, then the corneas and everything's okay, the cornea is free to go.
Okay, that's excellent.
Yes.
Perfect. Thank you very, very much for that wonderful presentation. It's not something that—
No, thank you.
So it was really interesting to know more about that.
Thank you so much.
Okay, thank you. And we're also looking forward to perhaps when we run the session again, maybe we'll have more information on the placenta donation at that stage.
Oh, by that stage, we definitely will. We'll have more information on that as well.
Okay, excellent. Looking forward to hearing about that. Thank you so much.
Thank you.
Okay, so we can move on to, I don't see any more hands. So I think we can move on to the presentation from Bone SA.
Okay, can I share my screen now?
Yes, you can. Thank you so much.
Can you see that?
It's loading, so we should in the next few seconds. Yes, we can. You can go ahead. Thank you so much, Tracy.
Okay. All right, thank you very much for the opportunity to give this presentation. As Rake has already said and Carol has already said, awareness is crisis we have at the moment, and the more people we can give our little presentation to, the more opportunities we have to get donors. I am not employed by Bone SA. I'm actually employed by KZN Eye Bank as a coordinator. But in 2008, we were approached by Bone SA about the femoral head program, and asked us to facilitate and look after the program within KZN. And that's one of my responsibility now. I look after that program on behalf of Bone SA. With the femoral head program, it's one of the good feel things about transplant and donation is that in the other transplants, patients being donating, obviously tragedies happen in somebody's life and one of their loved ones had to pass, and that they've now donated their organs or tissues. For the femoral head program, that's not the case. Any patient going for a hip replacement is now considered a donor, and we can then ask that patient themselves, would they like to consider donating their femoral heads prior to going to theatre. So it's a good feel one. Nobody has to die for all of us to get this program to run. Okay, so we obviously want to promote this for patients with disabilities and diseases and injuries. And any bone-related products is what Bone SA does. Carol mentioned that the CTE, which is a Center for Tissue Engineering, which is based in Joburg, they also run a tissue bank where they collect bone and they process it, but Bone SA is the only one that distributes bone. Now Bone SA has their own tissue bank, which is down in the Cape, which is now called Vitanova. So we have our own little labs which now process the bone, and from there it's distributed to the different hospitals. And there's also not only private hospitals, this is also for the government hospitals. So any patient or any orthopedic surgeon that is requiring any sort of bone for bone grafts will then come from Bone SA. The problems we have, obviously, we said it was a good feel in the program where you don't have to actually die, but we still have our challenges, because although some people still go on their cultural beliefs, they don't believe that they could do it, personal differences, they're not too sure, ethnic and your ancestral problems and things like that. But also too, I think the biggest problem is the lack of awareness. People don't know about the femoral head program, which is very unfortunate, because we throw that bone away every day. In the end of 2018, South Africa had to import bone from other countries because we had a shortage of bone. We don't have that available to us now because of COVID. We actually have a shortage of bone worldwide. And if we don't get this program up and running properly in South Africa, we're not going to have enough bone to supply our hospitals and our orthopedic surgeons and all these patients who are waiting for some sort of graft to be done. So it's critical at the moment. And I think with the last statistics was put in is that we've got maybe now less than 6 months of supply, which is very worrying at the moment. And like I say, we don't have the option to be able to import bone anymore. So we have to get the running. Yeah, in Durban at the moment, I've only got 5 hospitals running in KZN at the moment, and unfortunately all only private hospitals. So yes, we would really, really appreciate the opportunity to try and roll out this program into the government sector as well, to help us to manage this program, to have more donors. The more donors we have, the more product we will have, the more the patients will benefit from it. So yes, we are really reliant on everybody to help us pull all our resources to try and get this program running for the benefit of all the patients who are requiring some sort of bone graft. Our primary target market obviously is the orthopedic, spinal and neurosurgeons, and your maxillofacial surgeons and your orthodontists. So those are the patients that we the doctors that we are our primary target markets. So those doctors are going to require the stuff in the hospitals. So yeah, we are trying our best to actually get as much of the product out there for them, so we do not run into that issue where we now say, what do we do now? We do not have enough of this product for our patients. Surgeries at the moment are actually a bit of the problems, all being put on hold. No elective surgeries have been done because of the COVID. So we took quite a fall in with our donors that were femoral heads that were donated. End of November last year, we actually had a nice influx when the patients were going to theatre and they were getting their hip replacements. But obviously that now has come down to a little bit of a standstill because we just don't have the time to go through to theatre yet because of COVID. So I'm hoping that will come something that we can have a look hopefully soon, so we can start getting those femoral heads so we can process them and get the products out to the hospitals, so we can get those patients sorted. Just a little picture there. This is what our lab looks down now in Cape Town. It's quite a state-of-the-art of a medical facility. I'm quite proud of it. It's got a nice quarantine area, which the bone has to remain in. So when they receive the bone goes to a quarantine area, which will remain in that quarantine area until such time as the bloods come back that we have to take. And if all comes back clear, then the bone will then be processed from there. So this is what it looks like down in Cape Town. So, okay, so the shortage, obviously, the thing for patients that we're looking for, well, patients that we need to be grafted, of your patients that have bone cancer, It's for children with long-term TB on the spine, spinal fusions. Tooth implants, a lot of people don't know that. They go to the dentist and they think, oh, the dentist said, okay, we're just going to put some bone cement. People don't realize what actually comes from. It actually comes from donor bone. I think that everybody has that concept in their mind. It's like cement you buy at the hardware. It's not like that. People have no idea that it's actually bone cement comes from a bone and it comes from a human. Obviously, also 2 patients that have been involved in car accidents or have some sort of trauma, looking at for fusions for them, and patients that have revision of operations. Obviously, there is not, we had that opportunity, like I said, to import, but we don't have that luxury now because of COVID, and it's just very expensive. Ultimately, people think that there is no product as such that we can use artificial bone or products made from animals and things like that. And they tried that, but those patients just don't do well. It's body taken as a foreign body to the body, and the immune system just seems to fight that type of stuff. So the best, obviously, would be the actual bone, and that's what we're aiming to do, to alleviate and take out all these artificial stuff to give the patient a better chance at healing with the actual bone instead of having to substitute with artificial bones. Okay, so the problem that we have is that 80% of the bones that make up a human is your cortical hard bone. And that makes up 80% of them. That's your femur, your humerus, and your tibia, etc. But for all these spinal fusions, we need the 20% of it, and that's the cancellous bone. You can find that, and that's the one with the porous, and it's filled with red blood cells and marrow, and it's usually found in the vertebra or the ribs. But that area is very limited. If you look at how thin a vertebra is, by the time we get to process that and shape it into what we require, matchsticks or wedges and that, we actually left nothing to actually work with. So the best source that we can implement get from is your femoral head. So when you have your patients that go to theatre for a hip replacement, they take off the femoral head, and generally what happens with that is then it becomes the responsibility for the hospital to discard that. So you take it, and once you finish it, it's put into the bin or it's incinerated, and that's the end of it. Now we say, please don't do that. Give it to us. Let us use it, because that is our target. That is what we need. We need that bone. Just for your 80% of your heart bone, if we have a donor and the family has consented for hearts and livers and all those, and they've given consent for corneas, some of the patients' family will say they will donate the bone. Then we will take that bone as well, because there's also patients that need maybe a bone graft in a femoral or a tib fib, and that's what we consider is your patients with needs weight-bearing grafts, and that is the bone that we'll use for that. Your ones that do 20%, your cancellous bone is then used for spinal or your facial or things like that, where it's not considered as a weight-bearing graft. So if we do have one of those patients where the family has given us consent to remove all bones, that is normally done at the funeral home, and we can remove bones within 72 hours after the patient has passed. So we'll never do it in the hospital. Once the patient has been removed through to the funeral homes, we will then speak to the funeral homes, and they will help us facilitate that, and we'll go there and remove the bones at that facility. We'll do put other procedures in place afterwards, so once the patient leaves and goes to the funeral, they will see no difference in that. We do make sure we take the utmost respect of that patient and the patient's family. So again, Carol mentioned earlier on, when we do the corneas, we can have an open casket, and so it can be done when we remove the bone. Obviously, legal requirements is that we have to have a consent form. So as we said earlier on, Baker mentioned it, Carol mentioned as well, none of this can be done unless we have a consent form. So what happens if the patient comes through to hospital, it gets admitted, or goes to the pre-admission department, wherever the patient going, we will then provide them with a consent book. It's got 3 copies. It's got a white copy, a blue copy, and a yellow copy. The yellow copy remains in the book For future references, the white copy is what will accompany the femoral head through to our lab in Cape Town, and the blue copy remains on the patient's file. Should there be any complications later or anything that we need to refer to, we'll have a copy on the patient's file that they have given us consent to remove their femoral head. Instead of throwing it away, they have now donated it to us for be processed for at our labs down in Cape Town. So the consent form is basic: name and surname, ID, contact number, email address. It does mention in there that we have to take blood, which we'll run a test on. If the test comes back, like one of the tests we do is hepatitis, syphilis, HIV/AIDS. Should it come back as AIDS, we then provide them counselling sections with counsellors from our two-bank manager in Cape Town. It also mentions there, it's a non-profit, you can't be paid to donate your femoral head. If you want money for it, then we'll just say, sorry, thank you very much for considering donating, but unfortunately, no money will be exchanged for your bone. That is considered as trafficking in human tissue, which is illegal. It's purely based on helping other people, paying it forward instead of throwing it away. You're not just donating it to be processed to help other patients who are in need. We also do try to find, obviously, we mentioned as well that we don't have enough of awareness. So we have also, just to go on quickly to the next one, just to show you. So we make sure that the orthopedic surgeons as well, that they also are aware of the program. We go to visit the offices, make sure they have some pamphlets on what we do, some information brochures for their patients. So when the patients come into them and they're having their checkups, the doctor then can give them the information brochures. So it just gives the patients more awareness, but people don't know what happens to their bone when it gets diseased. When you ask them, do you know what happens? They have no idea, because they don't even know that they're actually going to lose a part of their bone and it's going to be thrown away. So we give them that information, and then gives them a little bit more insight and a little more easier for them to make a decision to actually want to donate, instead of saying, oh, I didn't know that, I'm just going to throw it away. Why throw it away? Why be such a waste? Why not we just give it, pay it forward, and let somebody benefit from it? Okay. Okay. This is just the bottom part of the consent form. It just written in there some of the questions that were asked you. If you've ever been exposed to hepatitis, if you're HIV positive, just a few little medical questions that were asked, and then obviously the patient will sign, and is dated, and then a witness. And like I said, it comes in 3 copies. The white one will go with the femoral head, the blue one remains in the patient's file, and the yellow one remains in the book for future references. This is what our brochure looks like. So there's a couple of questions. Do you know what is the hip replacement patient? You can donate your femoral heads. And again, like I said, that people don't know that. So these are the information we provide them. They're going to get a chance to read it and then make a decision before they go to theatre. This would be something that they will consider. Like I say, this is the type of thing that we need to put out there so people know about it, because nobody knows that you can donate, but it's little things we know. So what happens in theatre? We'll go to theatre. The orthopedic surgeon will perform the femoral head removal. We provide 2 bags. One will go for the femoral head, and the other one will be for the bloods that will be taken and the consent form. The anaesthetist will take 3 vials of blood. Not all the anaesthetists will do this. So this is the basic how our proposal to the hospital, but we'll adapt it anyway, which will suit the hospital. So in some of the hospitals, I have the anaesthetists who take the blood for us. Some of the other hospitals, I have the Lancet come and draw the blood for us in the wards before the patient goes to theatre. And when the patient goes to theatre, they just send the blood down with the patient's file and the bags for the femoral head. So we will adapt this protocol and this program in any way which helps the hospital to help us get this program running within the hospital. So anaesthetists will draw the bloods. Obviously, we'll put patient stickers on, patient's details. The copy of the signed form will go into the bag as well. And then the femoral heads we provide them with a register in theatre as well, because we have to have a paper trail as to find out what happened to the tissue. So there will be a register. We provide the register as well for all theatres. We provide all the blood tubes. We provide all the bags. So there's no cost at all to the hospital to run this program. We bear all the costs in the sense of all the documentation that is required, the tubes that are required, the bags, the registers, the consent books. All the cost is borne by us. There will be no cost at all to the hospital to run this program. All we need then is to do is facilitate it for us and know that patients that are going through for femoral heads, for hip replacement, are potential donors. So once that's done and the femoral head has been removed, it's in the bag, it's got the patient's label, a sticker on, the bloods have been drawn, the consent forms in there. It is then put aside, and then we will then phone Lancet. So Lancet is the lab that we are working with, and they do all this free of charge for us. It's their community project that they run for us. So they will come down, they will collect the femoral head, they will take it back to their lab. They will spin the blood for us, and then they will put it into their freezer, and then they will send with the femoral head, and then they send it down to their main branch, which is in Lawn Street. It's opposite the city hospital. And then once a month, I go down and we collect the femoral heads, and then we'll courier down through to Cape Town. So they help us with that, and it's done free of charge. So the hospitals that we run the program at the moment is here in Durban. We run it at Gateway Hospital, we run it at Hillcrest, we run it at Westville, we run it at Interveni, and we run the program at Life Hilton Hospital. Hopefully we will be able to get a few more hospitals on board. We had a couple in the pipeline to put our proposal through, but unfortunately now due to COVID, access to the hospital is very difficult, and we need to actually go into the hospital to be able to speak to hospital managers, to be able to put the proposal through, and hopefully we could get that program running in other hospitals. And same as what we like to do at the government hospitals. You have patients that require this product, and we could get the hospitals on board in the government sector, so much more femoral heads would be obtained, and there's so much more product we would be able to produce, and we wouldn't be sitting in the crisis that we're sitting at the moment. We would have less than 6 months. So yes, it's vital that we can try and get these programs up and running in the other hospitals. Okay, so once we've got the femoral heads and we've sent it down to Cape Town, when it gets through to our main facility down in Cape Town at our labs, it goes into the quarantine. I mentioned that we have the quarantine area, and it remains there while we wait for the blood test to come back, which I mentioned already. We check for HIV, syphilis, and hepatitis B and C. Once that comes through and everything is negative, then the process of the bone then goes through from that. And what happens then is the femoral head is then stripped of all cartilage, and it is chemically washed until there's no blood or fat remains on that femoral head. So it almost looks like a dehydrated piece of bone by the time we finish with it. Okay, once it's at that stage, then it is hand cut according to what is required of specification. So there's all sorts of shapes. We get what they call a matchsticks, and it's literally looks like a matchstick. We get wedges, and small ones, big ones, and all sorts of different shapes that is normally required for the different procedures that is at the hospital. So we do all through all that, get the different things, and like I said, all hand cut. Once it's all ready, it is packaged, and then it is sent off for radiation. Gets a good dose of radiation. So if there's anything left on that stuff, it's definitely not going to survive on that. But obviously, before we get to that, we've eliminated any possibilities of any contamination as such on that bone. And once it's been set, it's had its radiation, it's obviously ready to be distributed and for the surgeons to be used. The process ensures that we make sure that the bone is surgically clean, it is definitely disease-free, and that it is safe to be used for all grafts or implants. So yes, basically that is the program what we're trying to run. And like I said already, we are desperately trying to get as many hospitals on board with this program. It's a good field program. Nobody has to die to be able to donate your femoral heads. If we, for any reason, we have collected a femoral head and we've gone back to the lab and it has some sort of problems with it, and they made a decision that maybe it's not best to utilize this bone, it is then used for research purposes. So we do tell the patients that should there be anything wrong with the bone or something that comes back that maybe we decide not to utilize the bone, it's still not going to be lost. It will still be used for research purposes. So yes, we are in desperate need. And like I say, if we throw away this bone every single day, and by getting the patients to actually donate their femoral head, it actually helps the hospitals as well, because once the femoral head is removed and it is placed on the table there in theatre, it actually becomes now the property of the hospital. And it's now the hospital's responsibility to discard or incinerate that bone at a cost. And they pay by weight. So some femoral heads are small little ones, they don't weigh so much, but then you've got your big patients that have big femoral heads, and to actually discard that costs the hospital. So if you've got a hospital who's doing 10 or 15 hip replacements a day, the cost of getting rid of that bone is quite essential. So by donating, you do not have that cost anymore. So the hospital benefits in the long run as well. In two ways, you get the products that you require for your surgeries, but you also too at a lower cost in the senses that it doesn't cost you to now get rid of that bone. I hope that covers all the actual foundations on how this actual femoral head works and the need that we are in to try and get this program going. We don't have, like I say, the luxury of actually importing. If we ever do get to have to import again, it's terribly costly. But at the stage where COVID-19 is, we have a shortage of bone worldwide. So I don't see that being an option for us at any time soon. So us here in South Africa, it is up to us to try and educate our people of South Africa regarding organ donation and tissue donation, and to try and to look after ourselves and our patients by actually promoting programs like this to get people more aware of actually what organ and tissue donation is all about, to actually make it easier for coordinators like myself, Reka and Carol, to be able to get the assistance and whatever our patients that are on the waiting list to try and help them, because believe me, when you can ask each one of them, it's not an easy task to be a coordinator. The demands are there for the patients, but the means of getting that for the patients is not that grateful and available to us. I hope that helps everybody. Thank you very much for the opportunity to tell you about our program, and I'm looking forward to having continue to be doing programs like this, because I think it is a very important part of letting our doctors know what options there are out there for them and for their patients, and about referring patients to us to help other patients. Thank you very much. Any questions?
Thank you so much, Tracy. That was really, really wonderful and very informative, because as I mentioned, it's not something that you would come across as commonly. So it was very interesting, and it's not even something you knew was happening. So thank you so much for sharing that information.
Pleasure.
Yeah. Before we started, there was a hand up, but unfortunately that person's not in the seminar anymore, but I did note it down and I will follow up. It was actually from Rizani. So I will follow up and see what his question was, and perhaps email it to you guys.
It'll be fine, no problem.
I did have some questions, but I'll just wait to see if anybody else would like to say something first. Check the chat. Okay, so far, nothing, but so I'm just going to go ahead and ask my questions quickly. Okay, so as I asked Carol, can you speak about the success rates of transplants? As well as, okay, so with matching, I'm assuming, as you mentioned about sizing and so forth. So just, yeah, if you could touch on the success rate and what factors influence the success rate of your transplants, as well as how our transplants donors and recipients match.
Are you mentioning, is this for the femoral heads as well?
No, this is solely for the femoral heads because I had raised it.
Okay. Yeah, there's also there's no criteria regarding with what blood group or tissue make and things like that. This is one of those where any bone can be used as a graft for any patients waiting for a graft. And obviously it's a graft. So what happens is they do the implant of the bone, so it'd be in with the spinal. And then what happens, it becomes the wedge between the patient's own bone and allows the bone then, or the patient's bone then, to fuse with that bone. So yes, we've had no problems. It's a great form of surgery in such for that, as that we don't have any rejections as such. So there isn't anything like blood group or tissue match, and there's a great success with your bone implants.
Okay, that's excellent. The follow-up question I had, how long can the treated and sized bones be stored until a donor is found?
Once we've got the bone through to down to a lab, and it's then actually processed and it's vacuum packed, it's actually then, it has a shelf life for many years because it's vacuum packed, and it's then only once it is open and implanted, and then it then fuses with the patient's own bone and the blood, then there is no period of time that we can only say and it doesn't have to be put in the refrigerator or anything like that. Once it's done, it actually, if you knew what it looks like, it's dry, its bone is dry, so it's not like I don't want to say this and people think I'm trying to get a thing, but it's not like a piece of bone that you'll find if you go to the butcher and you buy a piece of meat with the bone, that it's actually dried. So it can.
I suppose it can be similar to the specimens at the anatomy department, which have also been preservation.
Exactly, it's all dried. So once it's vacuum packed and it's got quite a long shelf life as such.
Yeah.
So it's not something that it has to be stored in certain conditions. It can just then be put onto the shelf, and when required, then you order it, as the hospital will order and say, I need matchsticks and stuff, and it can be then sent down to your pharmacy, which then will be sent through to the theatre when required.
Okay, that's excellent. Okay, so my last question, promise. I still don't see any hands, so I'm just going to go ahead and ask. Can you speak about the need for femoral head transplantation in developing versus developed countries? So, for example, you mentioned about TB, and I think that's important because South Africa is so is devastated so badly by TB, as well as other poorer countries across the world. You know, it's a disease most affected, so that affects mostly your developing countries. So that's just one of many things that would require people who need these kinds of transplantations. So yeah, can you just touch on the need across developing versus developed, and that also stems to needing support from governments and other organizations to facilitate this in countries?
Oh, definitely. There's definitely a need, but patients going for hip replacements go for various reasons. Some have got generally wear and tear, patients that have some sort of arthritis. But yes, there are a lot of patients that are having TB and obviously require that surgery, and then being, like you say, from the poorer part of our country. And there is a need for hip replacements as such. Younger and old, Bushveld doesn't have a specific age group as such. Just mentioning on the age group, and that we take femoral heads from anybody who's willing to donate. So even your little 85-year-olds that having to have a hip replacement because osteoporosis or some sort of disease in the femoral head or wear and tear, and they need to have a hip because we can still utilize that bone. So we're not limited to say we only have an age group between this age and that age. But funny enough, the younger patients, actually their bones don't do as well as the older bones when we do the actual processing with it in the labs. And some of the younger bones seem to be put on hold and used rather for research purposes. But yes, there's a great need. If you're looking at some of the statistics at some of the hospitals that I'm looking at, because I look at the statistics because then I know how many femoral heads are coming from our hospitals, and ones where we're lacking, we can do some more training. Some of the hospitals are doing something excesses of 20 to 30 femoral heads within 2 days, and that's a lot. And that's just one of the hospitals. Can you imagine what's happening at all the other hospitals that do orthopedic surgeons that we don't have access through to those statistics? So yes, there's a great need for it. And like I said already in the presentation, we at the point now where we actually don't know what to do because our resources now at least says to us less than 6 months. What do we do after that? And if this COVID doesn't let up anytime soon, for allowing us to actually start having our surgeries again and having those patients having their hip replacements, we don't have access to the femoral heads. I mean, we don't have access to the femoral heads. We can't process anything for the hospitals. So yes, it's happening. Surgeries are happening. Yes, we lose a lot of the femoral heads because we don't have access to those hospitals, but the patients are still there. Lots and lots of patients still will require some sort of graft, and we need the femoral heads to actually assist that program. So yes, it is, and like I say, also too, the government hospitals have those patients as well. There are a lot of patients that require that a hip replacement or some sort of grafting, and you need the product from us. And we saying to you, please help us to get this program running into your hospitals so we can get more femoral heads to make sure we have the necessary products to be able to assist you. Because if we don't do that, we're going to be find ourselves in some serious problems. And if we don't have the products, the patients are not going to go away. We're just going to get more and more patients that are going to require grafts. And the long-term thing for those patients, the pain and suffering that they have to go through because they can't get their grafts because we don't have the femoral heads or the product to assist them. It's a nightmare. I don't even want to think about those poor patients and the situation that they need for some sorts of surgery to alleviate their pain, or they help them with their spinal problems or their TB or things like that. And there's nothing that we can do to assist them because we just don't have the femoral heads to produce the product. So yes, it's really concerning. But yeah, there's a lot. It's a great need for this spinal fusions,
especially in
and
our
the product.
And I think the saddest thing is, like you mentioned, there's no cost, and everything is just there. It just needs that momentum and somebody to move it forward into the hospitals, which would make
yes, that's the thing. It doesn't cost the hospital anything. We provide all the documentation, we provide the registers, we provide the bags, we find all the tubes, and it's 3 tubes per patient. We provide all that, and we make sure that Lancet comes and collects it and spins it for us. So there's no cost to the hospital. We just need somebody to facilitate it for us, but then also to the hospital benefits, because the cost of actually getting rid of the bone and incinerating the bone, you don't have that cost anymore. That is taken away by just getting one patient to consent for your femoral heads, drops the cost of the hospital. So there is no cost to the hospital, and actually, in fact, the hospital gains from running the program.
Exactly. Well, I do hope that it is able to gain momentum soon, and I do hope COVID also goes away soon, because that's like impacts everybody in so many ways. We don't realize the multifaceted consequences of the pandemic and how it's affecting organizations like you guys. But hopefully things will turn around soon, and hopefully all 3 programs will start lifting up very soon. And as well, from SAMHSA's side, we'll continue to promote you guys and try to also help wherever we can, but within our resources. And as we mentioned, we will run the seminar again. I'm so sorry about how things happened. Regarding us with our registration, everything, like I mentioned, kind of fell apart these last 2 weeks, and a lot of students are moving back, traveling from other provinces across this week back to the university residence. So the timing, unfortunately, went quite, it didn't work out so well. But certainly once things settle, we'll definitely run skin because it's something that every medical student needs to hear.
Yeah. Thanks very much for the opportunity.
Oh, it's absolutely a pleasure.
Really
It's
appreciate
wonderful working with you. If there's, just want to check, does anybody else have any questions before we conclude the seminar? Doesn't look like that. Okay. Well, if anybody has questions, everybody knows me, so you can just send it through to me and I'll send it through to our presentation. So to our presenters. Thank you so much once again to Rekha, Carol, and Tracy for being here today with us and for giving us such an incredible and engaging talk. We really appreciate it on behalf of SAMHSA as well as UKZN medical students.
Thank you very much.
Thank you, Serini.
It's a pleasure. Take care, everybody. And thank you so much to all of our participants as well.
Thank you. Bye-bye.
Thank you. Bye-bye. Bye-bye.
Bye.